Welcome our keynote speaker for this afternoon, Professor Ann Roche. Ann is Professor and Director of the National Centre for Education and Training in Addiction at Flinders University. Previously, she was the Director of the Queensland Alcohol and Drug Research and Education Centre at the University of Queensland. She's had over 30 years' experience in public health and has worked as a researcher, educator and policy analyst, and has held academic posts at a number of different universities. For the last 25 years or so, she's worked specifically in the drug and alcohol field. She's published extensively, developed numerous educational programs, and undertaken an extensive array of research projects addressing research dissemination and workforce development issues, including worker well-being. Now, Ann's topic today starts off with a repetition of the word C. Changes and challenges confronting the alcohol and drug field. Please join me in welcoming Professor Ann Roche.
Thanks so much, David. And thank you very much to the organisers for the invitation to give this keynote presentation today. I'd like to acknowledge the Indigenous owners of the land, and I'd also like to acknowledge some particularly important people in the audience here today. We've just noticed that Professor Jim Rankin, who'd be known to some, but perhaps not everybody here, and Jim Rankin is probably the elder statesman in the alcohol and drug field in Australia, responsible for some of the most significant and major reforms that had furthered the developments in this field than probably any other single person, so I'd really like to acknowledge him. Please. In putting this presentation together over the last few months, I found myself struggling in terms of the sorts of things that I was wanting to address and to cover off, and also being confronted by the reality of what was happening across the alcohol and drug field in Australia throughout this year in particular. And so I want to start with an apology. Does this work? That way? Yes. So you've read the abstract. Essentially, I really do want to talk about some of the challenges that are confronting the field today. But in doing that, I was wanting to do it very much from a broad public health perspective and looking at the range of things beyond, outside the alcohol and drug field that impact us, that we're not always aware of on a day-to-day basis, but they are inextricably linked to the nature of the work that we do and the clients that we see and the policies that we develop. But throughout this year, I'm acutely aware, as everybody in this room would be, the extent to which some sectors have been, if not decimated, then really very badly buffeted and battered about by some of the major cutbacks that have occurred. And so it's not dissimilar, I think, to what's happened to some extent by Hurricane Sandy, where many things came crashing down around us over recent months, that the pathways that many of us were on got severely disrupted, and that we were very much left beached in many instances, and people still remain struggling to function the way that they had been. So I'd like to preface this presentation by saying that I am very much aware of the day-to-day difficulties, because what I now want to do is invite people to sort of move well and beyond that, whilst being aware of our day-to-day constraints and our limitations of our resources and the peculiar circumstances under which we sometimes find ourselves having to work. But that notwithstanding, the invitation in this presentation is for you to do some big picture thinking, some blue sky gazing. So what I'd invite all of us to do at this point in time is to step out of our day-to-day roles and think beyond the minutiae and the things that confront us from moment to moment, whether it be in a clinical setting, a policy setting, prevention or community-based work, but to step outside that so we can think about what those big drivers are. So this presentation will be very much about looking at alcohol and drug issues in the context of global issues. I want to focus on some of the things around inequality and the data that's emerging that indicates very clearly to us that these are some of the things that end up at our doorstep, that they actually drive quite significantly the sorts of problems that we deal with. So these big picture issues such as inequality, organised crime, global climate change, rising healthcare costs and the quality of life are absolutely essential to our understanding of what's happening within our sector. So whilst taking that big blue sky gaze, it's really helpful for us to look up from sort of the grassroots where we're operating and try and see beyond the woods for the trees. And in the course of this presentation, I will start very, very broadly and then over the course of about 5 or 6 different themes and issues, narrow down to some of the things that really do affect us very much at the coalface. But one of the first things that I thought it was relevant to touch on is the sort of thinking that's operating very broadly and globally. So the United Nations work recently looking at resilient people and resilient planet, and this discussion that's happening at the global level, in the context of the kind of volatility and uncertainty in both economic and between different countries, where economies are dealing with issues that they haven't had to confront for many, many decades, and the impact that that then has on people's well-being and their lives, and that then flows over to the manifestation in alcohol and drug issues. The concern about inequality, and inequality that's growing, and if we think that's not impacting us on Australia, then some of our data clearly suggests that that actually is the case. It is impacting on us greatly. And so at an international level, there's quite a strong impetus to look at sustainable growth and prosperity, and to look at the issue about well-being and how that is embedded within it. So issues around global justice and equity, and how the whole global ecology operates is absolutely crucial to our overall well-being. And so here we want to look at things around economic growth, environmental protection and social equity, and the argument from the UN perspective is that these are one and the same agendas. So think here very broadly, think big about what's causing us to sort of try and put in place the programs and services that we're attempting to. The UN report has suggested that sustainable development is about seeing that big picture, the whole picture, such as the critical links between food, water, land and energy. And one of the themes throughout this presentation will be about critical links and thinking beyond simply our own sector to what are the other links that both drive the issues and concerns that we have and will also help us to formulate resolutions and solutions to them. And it was a lovely quote from Mahatma Gandhi that's actually included in this UN report about the earth provides enough to satisfy every man's need, but not every man's greed. And that issue about equity is absolutely crucial to our understanding about what's happening to us as people universally across Australia at the moment. But if you move then to sort of drill down into some of the specifics of that many of you would already be familiar with the work of Richard Wilkinson and the spirit level, but I think it is particularly apposite to fold it into this presentation and thinking about these sorts of issues and specifically how it relates to us in Australia at this point in time. So those of you who are familiar with the spirit level research and the argument is that it sees that almost all social and health problems are related to social status and that they show the same tendency to get worse with bigger income differences within countries and sometimes within communities. And that issue about equity is absolutely pivotal. The more unequal a country is, the greater the prevalence of a range of social and health problems. And so whilst this is a quip that's included in this book, it actually carries quite a strong message about we're all on the same wavelength, everyone's on an antidepressant. But it's the issue about commonality and consistency that becomes really important. And so what Wilkinson's argument and data have shown quite clearly in the spirit level is health and social problems are worse in more unequal countries. And you see this relationship quite clearly, and at the top you will see in terms of this relationship is the United States, and Australia is not too far down, but I'll drill down into Australia in a little bit more detail. This is played out. This inequity is played out and manifests itself in a whole range of indicators, so around life expectancy, literacy, infant mortality, homicides, etc., that mental illness and alcohol and drugs feature very clearly in these data as well. So if you look at the prevalence of mental illness, it's higher in the more unequal and rich countries. And again, the United States features very highly, and not far behind that is Australia. So that there's a strong, clear, linear relationship between wealth, but inequality within the country, and the level of problems that we have in terms of mental health. If you haven't read the work, I'd really strongly recommend it to you. Similarly, you see a similar kind of relationship when we look at drug use, and it's more common in the more unequal countries. And again, you see Australia featuring very prominently in that regard. So whilst these are not the only contributors to some of our problems around mental health and drug use, it certainly is something that we need to think of when we're thinking big picture. It's absolutely crucial to our understanding not only of what's driving problems, but where the resolution to those problems might lie. Alcohol is a more complex picture than drugs, so we won't go into that here. They supplemented their report with some more up-to-date information, and I'm simply throwing that in to say that some of their data was challenged, they've redone it, and they come out with the same kind of linear relationships yet again. So let's turn to look then specifically at Australia for the moment, and some of the more recent data is the report that comes out of the Australian Government Social Inclusion Agenda, looking at how is Australia faring. And so this is the 2012 data, and sort of continuing the spirit level theme. Australia's level of inequality is one of the higher in the OECD countries, and our gap between rich and poor continues to rise. So the argument about what's happening internationally in terms of those big picture issues applies very much in Australia. It applies specifically to the issues that we're attempting to confront and resolve in relation to mental health and alcohol and drug issues. So it's not a tangential argument. Ironically, I don't think that's something that resonates particularly well with Australians. Most Australians will see themselves as being in good health and comfortably off. We tend not to be particularly or acutely aware of those kind of differences. But the same data from this compilation shows us that in 2011, 14% of all children under 15 lived in jobless families. We know that many of those children will end up having problems with alcohol and drugs and end up in our services relatively soon. So, we also know that there's a relationship that exists between, and this is the linkage theme running through the presentation, those who've been homeless for the last 10 years are 2 times more likely to have a physical disability and 3 times more likely to be a victim of violence and 4 times more likely to have a psychological disability. So that there's this strong level of interconnectedness when we start to look at these kinds of problems. So inequity drives with it a raft of problems. Similarly, we see 5% of the population experiencing multiple and complex disadvantages. That's 1 in, so 5% sounds relatively small, that's 1 in 20 individuals. And the issue about multiple disadvantage and multiple morbidities I'll pick up in a little while. So we also see concentrations of populations in particular pockets in our communities and suburbs where we live, and so that these things are not spread evenly across the community as well you would be aware of. And the other interesting change is we're starting to see, and there's a very important thing for us to grapple with in terms of our services and our programs, that we are now living longer, but some of the economic disruption that's occurred both internationally and within Australia in recent times has meant that many people at retirement age have been forced to stay in the paid workforce. There are many issues that are emerging around the ageing of the Australian workforce that we now need to contend with. Many of our methadone or OST clients are now much older than we probably ever thought they were going to be 20 or 30 years ago. And with age comes a whole range of special considerations about service needs and supports and about disabilities and about all sorts of health considerations. And some of the issues, and I'll touch on pharmaceutical issues in a little while, but many of the issues in terms of our services were never configured to look after people or address the concerns of people over 50, 60. Increasingly, we will have to do that. So, having given those few little snapshots of those particular scenarios, it raises the questions then, again thinking fairly broadly about, well, what should some of our responses be? And this is something that countries around the world have struggled with. To a very large extent, we're not well equipped to think in terms of broad systems responses. Some of the best work that's been undertaken in this area has come from Canada, and there's work being modelled on the Canadian approach in Australia and New South Wales at the moment. But it's particularly difficult. But thinking from a systems perspective is absolutely crucial to improving the services that we offer. And the Minister picked up on this morning, that we tend to have quite fragmented systems available to us. So drawing on the piece of work that was done in Canada now a couple of years ago, they make the point, and it is mirrored almost identically here in Australia, that the vast majority of Canadians, read Australians, are affected by substance use, don't use specialised services. And this is particularly important for us to bear in mind. They access other sectors of the healthcare system, such as social services, housing and education. We're actually missing these fantastic opportunities, not completely, but to a large extent, to tap in at earlier and probably more productive and effective stages. The challenge confronting us is to respond more effectively to all potential clients in a coordinated and in a multifaceted, broad range of ways, and offering services and supports that are interconnected. So providing these appropriate services and supports across this range of systems, it will reduce substance use problems, sorry, not reduce substance problems, but will improve the range of outcomes that we're attempting to achieve, both in terms of health, social functioning and criminal justice issues. So we know that we as a group collected here in this room can't tackle all of these issues on our own. We know that what's required of us is closer collaboration and partnership with some of the other key sectors, such as primary care, such as hospital-based, either the emergency departments or inpatient care, the specialised addiction services and looking for that better integration with them, and housing and employment, and also then looking at the issues about families, children and carers much more broadly. But it's easy enough to say these sorts of things about the need to operate within sort of an integrated, well-functioning sort of system. And those of you I mentioned at the outset have been fairly savaged by the system that they operated with at the beginning of the year. I again apologise for these sorts of lofty notions. But historically, we know that we've not been very good at doing this, that there has been little integration or effective communication within and between the systems within which we should be operating to provide these kind of services and supports. We know that there have been substantial and continue to be substantial gaps and barriers to access for people who have either existing significant problems or if we can predict fairly strongly and accurately that they're likely to emerge with great personal distress and strain for those individuals involved. And those individuals are required to navigate what was described in the Canadian report as this complex and ever-changing labyrinth of services and supports. So what's the goal? The goal here is to develop a tiered continuum of services and supports to address the broad spectrum of risks and harms conferred by substance use. So that was what they've outlined in the Canadian report. And I'd suggest to you that perhaps a tiered approach is probably even too simplistic. It's too layered and too simple when really you're looking at much more complex and integrated systems that are required. But I'll speak through briefly about what's proposed in that tiered approach to responses. For those of you who are interested in some of the tools that might be helpful to operationalise some of these sorts of things, the Canadian Centre for Substance Abuse on their website has quite a useful practical toolbook called Systems Approaches Workbook. So the Canadians suggested that under this kind of tiered and integrated system, there's at least 5 different categories. Now, having worked in this system for nearly 30 years, I've worked specifically in some services where I'd say, yeah, our service actually did operate and did offer many of those elements within that tiered structure, and I suspect that for many of us in the room, that's the same. The second layer that I've highlighted is the area where I think we have least degree of integration but most degree of potential scope to work into the future. So many of us would be familiar with some of the community-based outreach services and supports, and I think Australia has done remarkably well with many of those. The third one is in terms of services and supports for secondary harm. So this is sort of your basic sort of risk management and assessment and referral and so forth. We offer good intensive services for multiple, not so much for multiple and complex problems, but we do offer good intensive services, and we do, I think, cater quite well for some of our acute and chronic and complex problems. What we don't do particularly well in this hierarchical structure that they've suggested is the integration for early intervention and identification across primary care, social services, housing and emergency care. This to me is the great void, and that if we're to run our services better and more effectively, we need to be doing more at that second level because that prevents a whole series of other problems emerging down the track. But one of the other big shifts that's going to occur and confront us into the coming 5 and 10 years, if we look back in the last decade, we became appropriately so very focused on comorbidities. And what I'd suggest to you is that what will focus our attention even more into the next decade are multiple morbidities. And there's a very interesting paper that in The Lancet, a recent issue in The Lancet, that pulls a lot of this relevant data together. So looking at the epidemiology of multiple morbidities and the implications for healthcare research and medical education is probably the precipice that we now find ourselves on. Multiple morbidities involve the management of the rising prevalence of long-term disorders, and it's going to be the main challenge facing governments and healthcare systems worldwide. And it's to do with a number of factors, partly our longevity, partly people with disabilities also live for a lot longer, and that we're recognising the interrelationship between a range of morbidities or problems that an individual carries. We don't just see one single issue any longer, or should not be seeing one single issue. The use of many services to manage individual diseases, and it's written very much from a medical perspective, can become duplicative and inefficient, and it's burdensome and unsafe for patients and clients because of poor coordination or integration. And multiple morbidities progressively become more common with age. So I would suggest to you that this is something that's going to sort of occupy, or should be occupying, our thinking into the future. And similarly, a recent paper in the Australian-New Zealand Journal of Public Health picked up on the issue as simply about, in this instance, looking at two concurring issues: physical health problems and mental illness. So Australian adults with a diagnosis for mental illness have a significantly increased likelihood of a physical health disorder. And this helps us to move some way towards thinking from a multiple morbidities paradigm. So what's this thing going to translate into, and how do we start to prioritise what are some of the areas where we really do want to direct our efforts and our resources? And so clearly in the Australian context, the hands-down winner in this regard has got to be the needs of Indigenous Australians. Whether it's mental health issues or alcohol and drug issues, the Indigenous Australians' needs are profound against any measure. Similarly, prisoners in the Australian context are also, we now have better and more recent data that show the extent to which prisoners suffer from really extreme levels of problems in relation to mental health issues and alcohol and drugs. The second cluster there, the colours are showing up, that we will need to be thinking of. So they'd be my two priority hit lists, if you like. But what will underpin our approaches increasingly into the future is how do we tackle these issues from a social inequities perspective, and how do we see alcohol and drugs issues within an inequities perspective, and then how do we move beyond our own narrow, very narrow Cinderella area, if you like, that it has been on the fringe of many of these other mainstream health and social services for a long time. How do we move to operate in a much more interconnected way than we've ever done previously? And the final little cluster of issues at the bottom there, some of the things, and again, the Minister touched on some of these earlier, the issue about children and child protection and child wellbeing is taking a prominence in Australia and other places that we've not seen previously. And it makes extremely good logical sense that from those experiences, many of the subsequent alcohol and drugs and mental health problems flow. There are many opportunities today to do our business better in terms of child wellbeing. The other emerging issue I would suggest to you, and the international data suggests this as well, is that what's happening in terms of pharmaceutical drug misuse, it has been speculated, may displace black market drugs into the not distant future. As we have an ageing population and a population suffering, with 20% of the Australian population suffering chronic pain, the issue about how we better manage pharmaceutical drug misuse will be absolutely paramount to the efficiency of our services. It's a big challenge because what we've developed over the last 30 or 40 years has not been designed to address these particular issues and many of these types of clients. So again, I suggest to you that we're on the cusp of looking at how we change those services quite substantially and respond better to our ageing populations and issues such as pain management in a much more integrated way. And I've just taking the time, throwing in a little bit of data about that particular issue because it's been quite topical. But I suggest it's not just a transient issue. I would suggest that it's worthwhile thinking very seriously about it because it's likely to change the whole face of our services and the nature of the business that we do into the future. And so many of you would be very familiar with these data at this stage because the last year or two there's been a fair degree of exposure in regard to looking at this exponential increase, unparalleled increase that we've seen, particularly around substances such as oxycodone and also fentanyl. And some of the data that's come out both from the Victorian coroners and also recent data from NDAC showing some of the harms around these increased levels of prescribing that are echoing what's occurred already in the United States, but not to the same extent so far. But some of these harms show the death rates for prescribed opioid use are now tracking up at a seriously disturbing rate. So these just aren't transient events that are occurring. As I said to you, I think these are some of the things that we need to be confronting and tackling head on because this is likely to change the nature of the business that we're doing. as is focusing very much and increasingly on how we better support children and children's wellbeing, whether they be the children of clients within our services or whether we were operating more closely with child and family services, that there's a major opportunity here for prevention that we've yet to take up. And it's worthwhile mentioning this particular book that Gabrielle Bammer was co-editor of about knowledge brokering to improve child wellbeing. It's one of the crucial cutting-edge issues for us at the moment. And similarly, the Demos Foundation has also just written, have produced a number of quite interesting and important tracks in relation to the role of parents and the role of wellbeing that I would recommend, children's wellbeing, that I would recommend to you. So I guess the other thing about focusing on children for the moment is one of the things, children and young people, that will drive and has been driving the nature of our services and how we actually deliver our messages to them, that as we deal with the thumb generation, that many of the services that we're now attempting to provide in our programs and our interventions will have to pivot very much around using electronic technology to address the style of interrelationships that young people have developed over very recent years. So I love this set of photographs, I had to share them. So if we move into then the second or third last bit of this presentation in terms of, well, where are we likely to be by 2020? And what will be the overriding issues that drive the way we think about issues in our sector and the way we do our work. Certainly the social determinants of health, I would suggest to you, will take a greater prominence than they've had for the last 5 to 10 years. That looking at early life experiences, and again, the wellbeing of young children is taking increasing prominence, the role of work and how its impact on us and our impact on our wellbeing. The issues around employment and unemployment and social exclusion become crucial. If you think back to that data from the spirit level, it starts to become blindingly clear what some of those relationships start to look like. But in terms of the responses, we need to look at integrated models of care. We need to understand better how to work with the mental health sector, the aged care sector, child and family sectors, Indigenous people, non-English speaking background individuals and prisoners. The solution that we're groping for here is going to be about how to better deal with these complex health needs and looking at comprehensive service models in a much more sophisticated way than I think we've been able to do to date. And in the policy context, there's a number of things that shape the way we do our business, and you'd be familiar with all of these kind of strategy documents. But they'll draw your attention to the one at the bottom, at the NHMRC Strategy Directions document, which has been out for discussion until the last 2 weeks. NHMRC at the moment are looking also at how we shape and fund and resource our research agenda, and I've unashamedly selected out some key things that I think are important. One is their emphasis on equity and population health outcomes and quality of life. And again, this will drive our thinking to a very large extent. NHMRC is saying very clearly what they're going to be doing is establishing integrated health research centres. So echoing what I was saying about the importance of having more integrated service delivery systems, that's also now needs to go hand in glove with integrated research. So no longer operating as separate disciplines or professional groups, but looking much more for integration across these areas. The other one that they emphasise is the issue about minimising waste and adverse events. And then there's no clearer example in our field than the opioid overdose deaths that we've seen from prescribed pharmaceuticals that we've been recently pulling out the data on. They also highlight the importance of realigning sector leadership and governance, and again, that's going to be crucial to us. So in terms of emerging areas of focus, and as I said, we're going to be drilling down and becoming more and more narrow, what's happening for us is that some of the things that we're now expected to do, sometimes with our shrinking resources and under our decimated services, given recent events, there's certainly a thrust and a push for us to operate at a level of quality and aiming for a level of excellence that's probably reasonably unprecedented in the past. So quality and quality frameworks is very much part of the rhetoric of today, as is outcomes and performance measures. And I know this rankles with many people in our field, that the notion of you're taking resources away, but you're saying to us we have to operate against these quality frameworks, and then we're going to have to produce the type of performance measures and indicators that we've never used before. So, but standards, accreditations issues, these will become, I think, bread and butter issues for us into the future. And, sorry, just in the interest of time, I will move on. The question becomes one of then, how do we actually sort of walk this tightrope? shrinking resources, expanding demands, huge aspirations in terms of how we should be working, not only effectively within our own sector, but now across a whole raft of different sectors as well. Another component within this is what's happening, again, not within our sector, but more broadly, is that there's a thrust to see the development of what's called interprofessional health education. And this is health education for groups such as doctors, nurses, and a whole range of health professionals. And so across the world, health systems are reviewing the narrow disciplined approach that we've taken to training up our workforces, and it would be remiss of me not to touch on the workforce issue. But there are major limitations with that particular approach, which has been in place for many, many decades. And as population growth changes, intergenerational changes are occurring, new technologies are emerging, and so forth, that there's this real push to see the way we upskill our health professionals and our health workforce change to one that is much more multidisciplinary in focus. And there's an argument that says that traditional models of patient care won't be able to meet the demands into the future, which we know, or ensure that those who live away from major resource centres, and particularly those in Australia in rural and remote areas, may not have access to services. Hence, the workforce will need to be more adaptable and able to work more effectively in teams. That there's an argument that we're going to be seeing these emergence of new models of care and enhanced community roles, and certainly greater cooperation between and among health professionals. It's argued that in this new emerging environment, health professionals will have to train together at both the undergraduate and vocational levels, and the traditional narrow view of health professional training, which is discipline-based, is argued, may well become a thing of the past, and that some of the kinds of comments that I'd share with you that people have made about this particular perspective, and then I'll tell you what my perspective is on it, is that I'd see it as one that enables you to maintain and develop your own core discipline skills, and also the capacity to work and understand other delivery professionals, their activities, their approaches, and the way in which you interact, and understanding your approach in greater depth, and understanding the practices and approaches of others, and so forth, involved in healthcare delivery. The Productivity Commission in 2005 argued that healthcare demand is expected to change in line with anticipated changes in the burden of disease facing the community, and this will fundamentally affect the models of care employed in delivery services and the number of types of healthcare workers that will be required, and the development of multidisciplinary approaches. Whilst in the past, most training and education in healthcare has been delivered using the learning objectives of a particular professional occupation, what is mooted is that this may well change into the future, and that this segregated approach is not appropriate for today's healthcare system, where complexity, technology and specialisation are the norm. Healthcare workers who are educated and trained to work together can reduce risks to patients themselves and their colleagues. So what we'll be confronted with, I'd suggest to you, is this ongoing battle for talent and human resources. And in many of the areas that we deal with, we already have seen a shrinking base from which we're operating. For those of you who have had a look at what happens with the NGO sector, in particular in the vet sector training, we've just completed a national survey of vet training providers, that the projected workforce needs in Australia, as shown in this red line here, is that we will see this massive increase in our demand for health and human services workers across Australia. And what the impetus is for generalised workers who can move between alcohol and drugs and mental health and aged care and childcare and so forth. I'd suggest to you that there's a perfect rationale for doing that, as we have seen. However, it may not necessarily be to the short-term advantage of the alcohol and drug field, where this is the very time when we're trying to increase our level of specialised knowledge and understanding. So, in the interest of time, let me just skip over some of these things. So in the last few minutes, I was trying to just pull this together. So what are some of our current emphases? Certainly around performance indicators and outcome measures. We've heard already a little scratch on the surface about some of the push towards recovery. There are many of these issues, some of them are highly contested, but it does highlight our need for sort of improved leadership in the area. And I'd like to end on a note of some degree of levity, because these are some fairly sober things. There is a delightful paper, if you haven't come across this, that Andy Oxman and David Sackett and others wrote in 2005 called A Surrealistic, Mega analysis of redisorganisation theories. It's a totally tongue-in-cheek article. And many of you, right at this very time, will be experiencing high levels of redisorganisation in the services that you operate. And they've suggested that within these processes, there are several leadership styles that emerge: the mutt, the bulldog, the German shepherd, and the poodle. The mutt is characterised as the most common type of leader, self-focused with a need to piss all over everything to mark their territory. The bulldog, well-meaning but incompetent and dangerous when aroused. You can start to put names and faces to this as we go through. The German shepherd, bureaucratic, commonly suffer from anal retentiveness, which makes them irritable. And the poodle, ideological, focused on a specific peculiar way of looking at the world to the exclusion of empirical evidence, practical experience and common sense. But in wrapping up and pulling it together, what I'd suggest to you is that as we look into the future, that we do need to think upstream. We need to think in terms of what are some of those big picture global issues that drive both the way our communities are structured and the types of issues and problems that emerge for us, that many of them are so obvious and so predictable. And if you think that because we work at the coalface, we're not in a position to influence some of those things, I'd suggest to you that we can rethink many of those things. We actually can influence some of the upstream issues. Think outcomes, because that is the path for the future and the way of the future. We will be expected and it will be demanded of us to demonstrate outcomes of all different sorts. So we'll be looking at both ends of this continuum. Think partnerships and collaborations in a way that we've never done before, well outside of the alcohol and drug field and beyond some of our traditional allegiances, because as we attempt to deal with some of these very complex issues around inequity and multiple morbidities, we need to form quite different forms of alliances and allegiances. And finally, in the process of doing this, and this I don't need to tell people in this room, is that we will survive by being both flexible and resilient. Thank you for your time.